So first things first, hello everyone, and welcome to today's remote monitoring webinar. Can everyone say hi in the chat just so I can make sure everyone can hear us and can see us all good? So just a hi in the chat, please. There you go. Thank you very much. Beautiful, beautiful. That's good. If there is any technical issues as well, there's going to be someone on hand, myself, or we've got someone else from the team that will answer your questions. But it's all good because I've seen a lot of highs in there and nearly 100 people. That's fantastic, fantastic, fantastic. Also, just a little introduction, little shout out as well, housekeeping. There is a polls tab in the handouts tab, which throughout there'll be a notification in there. For the handouts, there's something in there now which people can download. And for the polls, when it comes to time for the polls, you'll see a little notification which you can participate in. And that's all from me today. So now what I'm going to do, I'm going to hand you over to Breed.
Thanks, Liam. Welcome everyone to what I expect to be a really inspirational 75 minutes. As Liam said, do feel free to introduce yourself in the chat, as who knows what amazing connections you may make with colleagues doing similar things today. Our last check, I think, shows we have about people from 43 countries registered. So amazing and fabulous opportunity for global collaboration here. A little about me, for those who don't know me. I'm Breed O'Brien, and I'm passionate about how we utilise technology to help solve real-world problems. I'm really not interested in tech for tech's sake, i.e. the shiny new thing, but I do like the AliveCore device. It's small and gets my vote. I'm interested in how we align people, process and technology to really improve care for citizens, and also to ensure tech isn't adding additional burden for our very stretched health and care teams. I've got a clinical and operational management background, both in the NHS and in Australia. I believe we've got some Aussies joining today. And I've worked in mainly acute trusts and at a system and national level. I'm currently working as a transformation advisor, but my most recent NHS role was as the National Director for Innovation and Digital Health in NHS England. I joined the national team during COVID, and it was during this time that I became aware of the work that Chris and Lauren are going to tell us about today. Today, for me, is a great example of continuous improvement and this sort of you said, we did approach that we often use as a positive example of responding to complaints. Of course, this example today doesn't originate from a complaint. Its origins come from a frontline team thinking about how things could be better. Even though Chris and the team were delighted with the AliveCore device and what it enabled for them, he also suggested quite quickly, and obviously told AliveCore colleagues too, that the process around using the AliveCore device for this mental health pathway could be so much more efficient if the calculation of the QT interval could be automated. And he and Lauren will tell us about this story today. I'm delighted to be chairing today too, though, because when we became aware of the work that North Tees were doing, my team and I spoke to other mental health teams across the country to check that this was genuinely a useful application of technology that warranted some national focus. Based on this, we secured funding nationally to enable other teams to also benefit from this. But in the discussions we had with other teams, one that remains very memorable to me was a forensic psychiatrist from Northeast London, where he told me how he'd used the device with an acutely psychotic patient sitting on a park bench and hence was able to start medication very promptly. For me, that was a story of how we need to meet and engage with patients where they need to be met and based on how acutely unwell they are. It's an example of being able to make a safe and timely clinical decision using the technology and the approach Lauren and Chris will reflect on today. So whilst today is about a specific mental health use case, it's safe to say there are probably many other care pathways where it's applicable, and I'd encourage you to think about those and pop ideas in the chat and really get our conversation going about how this can help our patients around the world. For those UK or England, people attending from England, if you've read the planning guidance this year, which has come out from NHS England in March, and someone will pop the link in the chat now, you'll see there are lots of opportunities to consider what we hear today and how it could perhaps help other initiatives. For me, I can already see opportunities to support our core 20+5 initiatives, i.e. our equity initiatives, safe administration of medication, our annual health check approach, and generally pathway transformation. But I do make no apology for repeating myself. as I hope today's session will demonstrate the importance of getting people, process and technology aligned to really see the impact. So Liam has outlined a little about the webinar platform we're using. We'll be putting resources mentioned throughout the presentation in the handouts tab, so you can just press download on the ones you wish to save and you'll have them. And I'd encourage you just to do that and let it happen in the background so you can really listen and engage with what's being said rather than trying to read things at the same time. And we'll share everything that's discussed with the slides after the session. Lauren and Chris will also do 2 polls which during the presentation, so that will appear in the tab, the polls tab next to the chat tab, so do participate in those. And do remember this is a session focused on shared learning, so be as interactive as possible and pop your questions, comments in the chat throughout and I'll ask them of our speakers at the end. If we don't get to cover them all today, we'll also commit to answering them afterwards and sending out to all our attendees. But if there's anything else that would be helpful to hear about, any other pathways where you feel this technology could be useful, or indeed if you'd like any further information on anything you heard today, just use the chat to pop your details in and the team will come back to you. So now to the really important part of today, I'd like to just hand over to Lauren and Krish, 2 amazing people that I've had the privilege to work with, and I'm going to let them introduce themselves and tell us their story. Thanks both.
Thank you, Breed, for the kind introduction. Good afternoon, everyone. I'm Mani Krishnan. I'm an old age psychiatrist and a specialty clinical director at TCS Guya Valley's NHS Foundation Trust in the Northeast. I've got my colleague Lauren with me. Lauren.
Hi everyone, I'm Lauren Bennett. I'm Innovations Project Manager at TCS Guya Valley's NHS, and I manage the innovations portfolio and worked on this project with Krish, which was just fantastic.
Thank you, Lauren. So we're going to talk about how we use this portable handheld device and for antipsychotic monitoring and how we overcome the barriers during pandemic. Before anything we do, we'll just give some quick disclosures. The pilot was funded by the Academic Health Sciences Network, which is now the Health Innovation. And also there was a national rollout with the help of the NHSX, which Breed was instrumental in helping us. And then we've spoken in various events and I've also been a specialist advisor at the NICE Early Value Evaluation. Both myself and Lauren have spoken about our experience, even though we have explained what TUVE has done, that's our trust. As a trust, we do not have any direct endorsement of any product from this presentation, but we would like to share our excellent experience. So much for disclosure. And then it is delighted to speak to you. And as Breed said, it's a shared learning. We're going to share our learning and we'll be very curious to hear about what you guys think of that. And I think we're going to start with the poll. So just to engage you guys, if you want to tell me where you are, what kind of, work professional group you're from, clinicians, operational managers, patients, carers, others. We didn't want to put too many options. So we've got 145 people online right now and 36% about clinicians working in psychiatry, 12% other specialty, 47% others. So it could be, healthcare background or business background or technology. We've got about 8% patient and carers, which is really good. And we've got operational managers. So we've got clinicians, experts, patients, operational. So such a wide, excuse me, I've got a frog in the throat. So wide variety of people. Thank you for going to give a couple of minutes for people to click on the button. So once we reach about 80%, we will move on to the next slide. Okay, right. So thank you for your engagement. Still 40, 30, 40 is others, 30% is clinicians. So let's move on to the next one. So just to set the scene on what was the problem. I'm sure most of you are aware if you are in this meeting today, it is about antipsychotic monitoring and what are the problems with antipsychotics and cardiac effects. They can cause arrhythmias, syncope, QT prolongation, and tosse de pointes, which is a life-threatening heart arrhythmia and which can result in sudden cardiac death. So during the pandemic, we encountered an additional challenge. There was lockdown, there was shielding of patients, especially I work in old age psychiatry. Older people were shielded and they were isolated. The family were not going to see them because they were worried they will pass the bug. So clearly, there was a lot of problems with social isolation. And then still, people were mentally unwell, and still we needed to give medication. And the risk of side effects were really important that we need to tackle. Uh, and there was also a lot of increased mental health breakdown during the pandemic, and we wanted to know how we can initiate this medication safely. And just to put it in a context, at this moment in time, there are about 750,000 patients might be on an antipsychotic. 1 in 100 are adults affected by schizophrenia. And then, as I already alluded to, prolonged QT could cause sudden cardiac death. So just for, I'm sure you are all aware of the conventional ECG, where you might have to, strip them up to the waist and put sticky electrodes all along the chest and both the arms and the leg. And so there's a lot of invasiveness here, especially with people with psychological difficulties. Some people might have anxiety, panic attack, agoraphobia, or trauma when they wouldn't like other people to touch their body. So it can be quite intrusive. And then compared to the current device, the portable device, which is just a small device with no wires, no sticky plasters, and then straightforward to your smartphone. And during pandemic, what we found was one of the medications, hydroxychloroquine, also causes QT prolongation. So in America, the FDA gave an emergency authorization for cardiomobile 6-lead device for QT measurement as a part of COVID management. And then the European Society for Cardiology also said that diagnosis and management of cardiovascular disease during COVID pandemic, they gave a regulation saying that the handheld ECG device has a high specificity for detecting QT prolongation and should be considered effective tool. So there were both American and European kind of an authorization during the pandemic. So what we did in T-side, I'm going to hand over to Lauren.
Thank you, Krish. So when Krish started working with us in the innovations team in R&D, we really wanted to clarify, how can this technology be embedded within the trust, and how can it help our service users, how can it help our colleagues and the services that we deliver. So part of our innovations pathway was to do some real world evaluation around basically just that, and hear from our service users, from our clinicians and our colleagues around what are the benefits for us, and how can we actually utilize that within the trust and implement it in our pathways and create a new pathway, which is what we did do. So to do this, we procured 30 devices, and it was the real world evaluation funded by Health Innovations North East North Cumbria, or was HSN at the time. So within the evaluation, we procured these 30 devices and we shared them among our community and our inpatient teams as well. 3 areas were in older adult psychiatry teams, 2 areas of general adult psychiatry teams, and in our inpatient services as well. And excuse me, I think this included our forensics inpatient services too. We developed a local operating manual, and that was co-developed with the people who would actually be using the devices. We really wanted to make sure that the operating manuals that we were actually going to be developing were co-developed with those who would actually use the device. And we really wanted to know what would be valuable to be within that document to you. So we did co-develop that, and we got approval from our COVID Gold Command as well. Excuse me. What we also did within this pilot, I'll just go back one, thank you. What we did as well is we co-created our feedback surveys for staff and service users to see what's important to us as a trust in what we would like to collate in terms of evidence, what's valuable for us, and then what can we generate around how this technology can actually help. What are those factors and those variables that we really want to measure? So we co-created the feedback surveys with our staff and service users, along with doing a cost and time analysis. You know, is it going to save any potential costs associated with this compared to current practice of using the 12 lead? And is there any time savings as well? Can we potentially reduce 2 appointments into 1 by implementing this technology, for example? And finally, last but certainly not least, the clinical safety case. Myself and Krish and many others within the trust worked really, really hard on this clinical safety case to make sure that it was clinically safe for us to use in the trust, which we completed. And I do say it took part of my soul doing that. So, but it was absolutely worth it and necessary. So yeah, thank you. And moving on. So the real world evaluation generated some really, really valuable and successful feedback and data. We then, as a result, we worked with CNTW, our neighbouring trust. NHSX actually funded an expansion and validation of our real world evaluation project. And this involved 140 devices that were split between both trusts. Again, co-creation as a theme, you know, we value it so much within the trust that we wanted to make sure we'd really spread that across everything we were doing for this project. So we worked with CNTW to make sure that we had a shared education materials for clinicians who were implementing the technology, and a shared operating manual as well, just to make sure everything was streamlined and we were all working from, you know, the same hymn sheet. So we co-created those, and that generated the same really successful results across both trusts. And as a result of this, NHSX funded 1,200 devices across England, which I believe trusts were then able to bid for to utilise within their services and their trusts as well, as a result of our project. So we're really pleased with that. Over to you, Krish.
Yeah, so having gone through America, Europe, T-side, we also managed to do a project in India. In fact, the author is joined the meeting. Hi, Swarna. So from India. So we tried to do an evaluation, real life evaluation of what we did in our country in India, and we found exactly similar kind of result, whereby it was easy to use. The results were significantly correlated with the 12 lead, and less invasive and also dignified. So, and we presented this at a Royal College conference in April. And somebody asked again in the question, so just break the presentation. They asked how big is the device. So that's, I'm not going to show my credit card number. That's my NHS card. And it's as big as that, just for people to know. So that's my NHS card, and this is the device. Sorry, I'm having right to left problem here. So that's the size of it. So we started developing our own training. Initially, we had it like a bit of a 10 A4 sheets of instruction, but now we have developed like a web-based training to our staff. We have 7,000 staff in our trust, so that they can go through how to do the procedure. And also somebody asked, is this device only for ECG purposes? Absolutely, only for 6-lead ECG. So having done the UK expansion with support of Breed and colleagues and NHS Digital, we're pleased to say that currently over 50 UK institutions have adopted the cardiomobile, replicating similar pathway to us. Got a second poll coming. What is your experience with using ECG? Okay, there's about 12% who have used handheld, which is good. About 20% both. No experience is 26%. So majority still using the 12 lead. Yeah, that's how it looks like. Thank you so much for that. And just to give our journey, as I mentioned, we started our journey in April 2020, like straight away as soon as we got the initial discussion with the FDA clearance. And June, the European Society of Cardiology, they uh, gave a recommendation, and then in October 2020, we did a real world evaluation, and then in August 2021, our neighboring trust did the expansion, and then September 2021. So within a year of our initial pilot, we had a kind of a national adoption. And then around September 2021, we had NICE contacted us for asking whether we should be able to do this as a NICE evaluation. They used a new process called early value assessment to reduce some of the barriers of the long drawn NICE technology appraisal kind of a process. And we were fortunate to be one of the very first technological device that's being assessed in this way. And also to be successful and get a NICE recommendation. Unfortunately, due to by then, as you already think, by 2021, pandemic was receding, and then the processes and barriers started going up, which meant that there was a delay because the pandemic helped us to break the barriers. As soon as the pandemic was receding, the barriers were put up. And there was only I'm being very candid here, forgive me. There was one single process called DTAC kind of approval. Because of that, the NICE kind of paused the recommendation. It took nearly a year. So by August 21, we should have had the NICE approval, but it came in September 2023. So it was August 22 to September 23. It's nearly one year because of that lack of that process. But never mind, we did get there. And so NICE health technology evaluation has clearly indicated that this is probably the first and the only NICE recommended personal ECG device for QT monitoring. And then you will be able to read the information on the highlights. The main things are, it has the potential to improve care and help create more effective pathway, and also allow ECG recording with less need for undressing without using conductive stickers, which I mentioned earlier on. And also, it can be done by our community psychiatric nurses during their routine visit. Generally, what will happen is they'll go on a visit, they'll come back to me and say this patient needs ECG. We get somebody else to go and do an ECG or ask their primary care provider to do an ECG. So it can take multiple stages, especially if you're going to initiate a patient on an antipsychotic. It can take a very long time, up to 2 days sometimes, or even a week. So, and also, as I mentioned earlier, people who have had trauma, anxiety, all those things, and also due to cultural and religious beliefs, they may not be very comfortable undressing. So we did a separate kind of a patient carer evaluation where almost like everyone felt that this is really an important aspect of their invasive treatment. So that was the highlight from the NICE recommendation. Is that you, Lauren?
It is, yeah. Thank you, Krish. So this is what Chris developed. So it's the TEAS remote ECG pathway, and this is how we implemented the technology within our pathways in TUV. I'll just pause there a second. I know there is a question around the benefits, and we are going to come on in a couple of slides, I believe, to look at the benefits of, the results from our actual evaluation. So we will be answering that one. So our TEAS remote ECG pathway, this embedded the technology within the pathway. So it begins with antipsychotic initiation or monitoring appointment, leading on to using the 6-lead ECG combined with the community nurse appointment. So this was really important to us, as it actually combined 2 appointments, as Chris had mentioned, into the one, which saved a lot of time for our clinicians, who could then use that time that they'd saved with therapeutic activities, etc., with our service users. So within the appointment, the patient holds a device on their left knee for only 30 seconds. That's all. It only takes 30 seconds. The ECG is then sent electronically to the consultant's nhs.net email account. Again, there's a sustainability aspect to this as well. We're not having to use paper, and it takes it's a lot quicker because it's sent straight away to the nhs.net email account immediately. And then they await the consultant decision on antipsychotic medication outcomes. I know Chris has got a really great example of when this has happened real, live. I don't know if you want to share that, Chris. I think you pulled up at the side of the road at one point. I know I'm putting you on the spot.
I think there are 2 things I would say. Again, when somebody rang me, there was a psychotic patient, so they rang me and say, we need to start this medication ASAP. And then luckily that particular nurse had the device. So I said, can you do it? And she said, yeah. I said, can you ping it to me? So I just went to a kind of a roadside parking, looked at the ECG, QT was fine. I said, yeah, start the patient on X medication straight away. And she was a nurse prescriber as well. So she were able to prescribe straight away. And the second one I would say is, they saw a psychotic patient in a community, and the patient was an amputee. So he had a left below knee amputation. So they were like freaking out. What do we do? But because those medics, this need to create an endo-one triangle, basically 2 sides and the left limb. Somebody asked the question, does it have to be left knee? Absolutely, yes, left knee. So ask the nurse to use the device on the stump of the amputation leg, and then we still got the ECG, and we were able to start the patient on medication. Yeah. So those are the 2 clinical examples. Yeah.
Thanks, Chris. So we also looked at the enablers and limitations. Again, with any improvement project, this is something we're really interested in collating from our clinicians and service users. And for enablers, we found it was a streamlined pathway for service users, quick decision making, as Chris has just demonstrated just now in those examples. Limitations, this came up quite a lot, is that it did actually have an extra manual step to calculate the QT. So once the ECG sent to the clinician's email address, they then had to, I'll use the word had, to calculate the QT right then. But I think it didn't take too much time, but regardless, it's still an extra step that our clinicians didn't have to take with the 12 lead. However, I know that there is now a solution to that, which we'll be coming on to a little bit later. So here's some results from our real world evaluation. So 272 patients responded and had actually used the 6-lead ECG. So when comparing the CardioMobile 6-lead ECG device to the usual 12-lead, we were really looking for that comparison evaluation data in antipsychotic medication monitoring. These are the things that it became apparent that we were interested in looking at. Which one's best for dignity and privacy, which one's easier to use from a patient perspective, which one's most comfortable for the patient, which one's least intrusive for the patient, and which ECG device would our patients prefer to use in their future tests. So these were the different variables that we were looking at in our evaluation. And 100, so we would, I'll just give a bit of background here. We started off when Chris and I had been presenting this for this project for a while now. We did start off actually presenting this as a graph. However, it got quite confusing because there was only, you know, green columns, and that's because 100% of service users agreed that against each of these variables, they preferred the 6 leads. You know, it was more dignity and privacy, best for that. It was easier to use, it was most comfortable, least intrusive, and they preferred it for future tests. So 100% of our service users actually stated that. So that was some of our service user feedback. And we generated some qualitative feedback as well. That was that it was loads quicker, less intrusive, easier and cool, and there is no sticky stuff left on you. So that was some really valuable, you know, qualitative feedback from our patients too. Now we're going to move on to a video from Evelyn Rodriguez, one of our community mental health nurses in the trust, who helped us quite a lot on this project and who uses it within practice today. So if we can play video 1, that would be great. Thank you.
To us, the feedback we got from the patient was, first, they couldn't believe that there was a device that could do the ECG remotely, and the feedback from staff initially was also good because you didn't need a lot of training to do the ECG. Everyone was very keen to make a start on this, but by having the device now, it cut down a lot of the steps in between, saving us a lot of time and resources.
Thank you. That's just a snippet of that video in there. And for staff feedback, again, we really wanted to collate service users and staff feedback. I won't read through them all, but one of them that we pick out that's quite, you know, if you took it off me, I would cry. So that was some results from our staff feedback as well. It's very light, easy to use, etc. But I think we will be sharing these slides, so you're more than welcome, you know, to have a look through those. And here's just a bit of an infographic around some of the time and cost savings that we did. So we found that it saved 17.5 minutes per ECG, 72 hours saved per team per year. What could we be doing with those 72 hours for our service users instead of doing a really lengthy ECG? That was really important to us. And then some cost savings of around 327,500 per year if all of our 85 teams across the trust were actually utilising this technology and this pathway. Okay, and we'll move on to video 2, please, from Matthew Ford Huggins, who's one of our community matrons.
In some of the teams. This stemmed from staff feeling uncertain about whether it would do what it needed to do within our service and who could actually use the ECG. So how we overcame those challenges was we actually had a question and answer session and did some myth busting to address staff concerns. We also did some training and explained why we should use it and when we can use it, and developed a standard process so that staff felt comfortable in its safe use.
Thank you. And we've just put one of our more recent staff testimonials on here that we found was actually quite powerful. I won't read through the whole quote. It's from one of our specialty doctors in our forensics inpatient services. But I will pick out this middle section. I managed to use this with more than one patient who never had an ECG in their life. So we found that quite powerful, actually, that this is the kind of impact it can have on service users who have perhaps refused ECGs previously up until actually utilising this 6-lead ECG. And I'll now pass over to Krish to discuss the other uses.
Thank you. So the question is buzzing, so we'll try to answer some of the questions as we go along as well. So even though we talked about uh, psychiatry, but even before we started, I did mention about COVID, but this has been used in oncology, methadone clinics, tuberculosis, and Parkinson's disease. And also, again, Om Prakash just now asked, is it tested or usable in atrial fibrillation? Yes, it's nice approved for AF. So in research in tuberculosis, again, MDR TB, multi-drug resistant tuberculosis, the medication can cause QT prolongation. So it has been evidence-based that it's been used there. And then Top Hat study, our colleagues Susanna Reeves and colleagues did it in UCL. Again, they used this device for their study. And in oncology, in breast cancer treatment, they use this. And again, just to name, there are nearly 250 medications that could prolong QT. And coming back to what we were doing once we have got our pilot and adoption in our trust, because we got the NICE recommendation with the condition, because NICE said that uh, they they would like further evidence generation. They put back to the clinicians and to the company saying that, it looks very useful, valid. Can we have more evidence for a final approval? So we have uh, put in a bid with multiple trust leads. Trust is leading on it with regard to doing some evidence generation, and then we will talk about that stage which Lauren mentioned. Only difference between the current conventional ECG and this one, because as of today, this doesn't have an algorithm that will automatically calculate QT. It's up to the clinicians to calculate it, even though it's not a big cumbersome procedure where you start with the starting of the Q to the end of the T, and then there are apps available that you can put that number of small squares. It will calculate the QT in multiple Fredericia or Bazette's method, but that adds that extra 5-7 minutes of step. In fact, our colleagues in India, they have that availability, and they were able to instantly get the QT. So we will give you a quick introduction on that. And then our own trust is looking at some research and collaboration. So this is the NIHR bid that we have put a bid in. And now is the next video.
And so this video is just taking you through the QT calculation that's automatic. So again, I know we've referenced the left knee, but it can be the left ankle as well. And you can see on the phone here, you then download the PDF and this is what it looks like. And it has the QT interval on there. And again, this is just referencing that you can also use it on the left knee. And I think this, Krish, is it right to say this would just come down to patient preference, the left knee or the left ankle, whichever they would prefer?
What we have used is left knee generally, but people have a tight jeans or a tight under lower garment that sometimes we have said you can just pull the socks down and you can use it. It's a practical thing. I don't think there's a big issue. And again, you saw in this instant QT, it does give the QT, and then Nicola just asked, is QTC? Yeah, corrected QT. That's what we do. And even when you are manually calculating, you can put the number of squares and get all the various formula for corrected QT. But this instant QT with the software will actually do that for you, the QT.
So I think that was just the video demonstration of the instant QT. And over to you, Krish. Thank you.
Yeah. So from the reflection from the project, I think again the question side is buzzing. The main things are, if we have lots of questions, we need an answer. So clinical curiosity is really important, and I'm sure Lauren and I can, enumerate so many stories of how people won't believe us, how even within our own trust, somebody complained to me as a clinical director that looks like somebody is using some dodgy device in this ward. Can you make sure that it's been reported? I felt like saying, "Oh, it's me. I'm the one who initiated the project." So people can't believe, and that technology can be enabled and also adopted. So that clinical curiosity, and then uh, challenging the status quo, and then even senior clinical leaders, not just within the trust, outside, uh, were challenging me. We don't want to be standing in front of a coroner's court that you are using a device that's not evidence based. Sometimes technology can be a bit frightening, but it was really helpful. I do thank COVID for this one, because COVID just put a stop to every unnecessary questioning, the bureaucratic questioning. So now look, NICE, I'm sure you all have reasonable respect about NICE. NICE has given a recommendation. You couldn't get a better validation than that. And then again, they did go through 9 months of serious and questioning, but co-creating really helped. So we always think of the clinician point of view, but patients, what do patients think? Sticky labels just for one QT measurement. Why do we need a 12 lead when the 6 lead is good enough? And also using that opportunity to drive challenge. I did speak to the company year before the start of the pandemic, because I heard about the device for atrial fibrillation. That was a single lead ECG, and that time it was not usable for QT, whereas the 6 lead was. And then it needed the pandemic to open the floodgates. And we still need to look at some of the process and procedures, which we mentioned earlier on. And thank you for the opportunity, and we'll try to answer some questions as we go along. And I know people have asked about various documents and things. We will try to address them as much as possible. I'll hand over to Breed.
Thank you both. Just as inspiring as I remember.